All right, all right. Well, good morning to everyone on the West Coast. Good afternoon to everyone on the East Coast, and to all you in between. I just hope you're having a great day. We are so excited to have you join us. I'm seeing those numbers climb quickly. This is a popular topic, I have to say. For those of you who've joined before, you know who I am. My name is Carrie Scott. I work in marketing at Spruce Health. You may or may not know our guest speaker today, Gabrielle Juliano Villani. I'm so excited to have her. She is a favorite. And in a second, I'm going to pass the torch and let her intro herself because she does that well. But I want to remind everybody why we're here today, and that is to discuss Medicare beyond the basics, because we had a basics webinar with Miss Gabrielle a little over a year ago, and it was a hit. And so this one is just going to be a slightly deeper dive. We're going to get into compliance strategies, common mistakes, and billing, all for you, just catered for this audience specifically. Just a little bit of housekeeping. So this session is being recorded. If for some reason you miss something, or you have to drop early, or you just want to revisit the content later, it is all going to be recorded, and I will send you that link later today so you have access to it. Gabrielle has also said that we can share the slides here. So if these are useful to you, I will include those in the follow-up email that I sent. One other item of note, the chat is disabled because sometimes that can get messy, but the Q&A is live and working, and we would love for you to drop your questions in there as you think of them. We will likely hold them for the end. That way that, Gabrielle can get through all of her content and the time that we have allotted, but please ask your questions, because that's why we have her here today, is to get to those live. I think I've covered just about everything in my spiel. For the bulk of you on this call, I think you know Spruce well, and you are either a customer or you've had some experience with Spruce. For those of you who are new to us, Spruce is a secure HIPAA compliant communication platform that enables providers and their patients to connect more seamlessly. It also helps in the collaboration and workflow and efficiency of the practice. And a lot of folks like to say it's like having their office in their pocket, because they're able to do everything from, their phone, their tablet, their computer, and that's fax and business phone and telehealth, all of it. For more info there, please head on over to our website. I don't want to take any more time talking about Spruce, because I want to get to the good stuff with Gabrielle. So I am going to dip back and turn my video off and pass the torch and let Gabrielle tell you a little bit about herself and get into the meat of what we're covering today. Thank you so much for being here. We're excited to have you.
Thank you for having me. I am obsessed with Spruce, and so I'm really happy to be here and be hosted by them because they are one of my favorite things to use. And if you've ever worked with me before, you know I'm obsessed with delegation and systems, and Spruce fits right in with that. So let's get started. If you don't know me, I'm Gabrielle. I am a licensed clinical social worker, and I previously owned a 15-person group practice that was almost entirely Medicare and Medicaid in the Denver, Colorado area. But I built that up a little too quickly and I got a little burnt out. And in 2021, I sold my practice. And since that time, I pivoted and I have been doing Medicare and Medicaid consulting all the way for people who are in solo practice, all the way up to some of the mental health tech platforms that you probably know very well, and everybody in between. And I help providers accept Medicare, Medicaid with credentialing, with correct billing, and compliance, and probably everybody's favorite, documentation and audit prep. And then the other part of my business is business coaching and consulting for entrepreneurs and wellness providers. And I help them scale their practice sustainably, add other income streams. And I also host burnout prevention retreats. And I would invite you to the next one, but it is sold out. And so if you want to get connected, I'll share my information later and we'll talk more about it then. But let's get in to what you're here for today. So, we are talking about compliance. I know that this is not like the most exciting topic in the world. However, it is really important, and I am going to do my best to make it as exciting as possible. As Carrie mentioned, we will share the slides. I'm totally fine with that. And then I also just want to give a quick disclosure that I'm a consultant. I do not work for Medicare. I don't represent Medicare or Medicaid, and so things are subject to change. So let's dive right in. We're going to talk a lot about audit prep. We're going to talk about compliance. We're going to talk about Medicare, Medicaid differences, and then some billing stuff as well. So as Carrie mentioned, I did do another like Medicare 101 basically with Spruce that you can still watch on YouTube. But I did want to do some foundational things here to make sure we're all on the same page. Everybody understands what we are talking about. So Medicare is a federal health insurance program, and it has kind of four parts. So part A is hospital insurance. This is for any inpatient care. If somebody is in the hospital, if they are in a skilled nursing facility or rehab following a surgery, that's part A. Hospice is part A, and usually home health care is also part A. Now, part B is where we really want to pay attention to, because as anybody who's an outpatient provider, which I think most people here probably are, this is us. This is what we fall under. This is outpatient care. So this is any preventative services, mental health services, that's a lot of us as well, and any specialists like primary care doctor, all that stuff falls under part B. I'm going to come back to part C. Part D is prescription drug coverage. So this one I don't talk about too much because most of the folks I work with, this doesn't really apply to us, but it's managed by private insurers and people who have regular straight Medicare from the government. They will usually add on part D because they want their prescriptions to be paid for. And now the fourth sort of optional part of Medicare is part C, and that's Medicare Advantage. And I want to be really clear about this, even though like if you've already accepted Medicare, you might already know this, but if you don't, it's super important because Medicare Advantage is a completely different thing from regular Medicare. It is managed by the private insurance companies. That means that you need to be credentialed with Medicare, regular Medicare, and with the private insurer and opted into their Medicare Advantage lines of payers. So I know that sounds like a lot, but if you have a client who has United Healthcare, Medicare Complete, that means you need to accept United, Medicare, and you have to have opted into United's Medicare Advantage lines of payers. And so Medicare Advantage is combined part A, part B, and usually part D. And people like these plans because they often, one, it's all combined, and they also get usually a lot of other benefits. Like sometimes they'll get coverage for hearing aids, they might get dental, they'll get silver sneakers. So that's usually why people go into Medicare Advantage. It's important for you to know because Medicare Advantage is separate from regular Medicare. They have different eligibility, different coverage, different rules, different requirements for prior authorizations, all of those things, and you would be billing them directly, not Medicare. So I know that was a lot, but very important that we start with that. The other important thing I want to talk about is Medicare versus Medicaid, because this is also confused. And even though Medicare and Medicaid are like besties and they hang out a lot, they are not the same thing, and you can have one without the other, or you can have both. Medicare is for people 65 and older and folks who have certain disabilities. So if they are on SSDI, Social Security Disability Insurance, for a certain amount of time, they can be on Medicare, or if they have end-stage renal disease. So that's important to note because my youngest Medicare client was actually 18. My oldest was 101. So just because somebody is young doesn't mean that they don't have Medicare. They could be disabled. It has premiums, deductibles, and co-pays and co-insurance. It is administered by the federal government, but then also with something called a MAC, which is a Medicare Administrative Contractor. And that just means that even though Medicare is national, each state is part of a region that is managed by this MAC. So, for example, if you are in Colorado, your MAC is called Novitas. You do everything with Novitas. If you have billing questions, if you're checking eligibility, that's who you go to. In California, it's Noridian. So there's different MACs out there. And if you don't know who yours is, or if you've never heard this before, you can go to my website, and on the resources tab, I have a map of the MACs and I have the links to all of them. And my website is just medicareconsultingfortherapists.com, and you'll find it all there. So the coverage is standard. Medicare covers 80%, and then there's a 20% coinsurance, and then provider participation is national. Now with Medicaid, first of all, Medicaid is always the payer of last resort. So if somebody has Medicare and Medicaid, Medicaid's always going to be secondary. It's income-based, so it's different than Medicare, and Medicaid is usually free. Usually there are some like low-cost plans that people can buy into as well, but for the most part, it's usually free. Coverage varies by state, and Medicaid is state specific. So this is important for people to know too, because I'll see this a lot, like in my Facebook group or when I'm consulting with people, like, oh, somebody in New York said this about Medicaid, but I'm in California and I thought it was this. And that's because it's different. So the coverage is different. The rates are different. The rules are different. Everything is very state specific, and sometimes even county specific, depending on where you're at. All right, so let's shift a little bit more into the compliance sphere and talk about documentation. Very important. We know if it wasn't documented, it didn't happen. And CMS has very specific criteria for what needs to be documented in every single progress note. And there are even more for the assessment, which I'm not going to talk too much about today. But first of all, you need the patient identification. Now, if you use an electronic health record or practice management software, an EMR, an EHR, a lot of this will be on there. And if you don't use one, then I would consider using one, because it will make your life a lot easier. So first of all, you need patient identification, their name, their date of birth, something to identify them. If you are, and I know we're talking about Medicare, but I'm just going to mention this. If you're a Medicaid provider, in most states, not necessarily all states, because I have only researched, I think 30 or 35 out of 50, and I have it all in a spreadsheet. In most states, Medicaid also wants the Medicaid number on every part of the chart, every piece of paper on the chart, every page of the chart has to have their Medicaid ID. And again, this is not across the board. It is state specific, and I'm talking about Medicaid. Medicare, name, date of birth, usually just two things that they could identify the client is enough. You will need the date and time of service. You're also going to need the duration. And I know that that seems very redundant, but I see people get dinged on audits all the time for this. It's redundant, I know, but they want to see started at 1, ended at 2, 60-minute duration. You need that on there. You also need the chief complaint or the purpose. Why is the client there? What do they need? The CPT code, what did you do? 90837, a 90834, 90791. The diagnosis, the location. So if it was in person or if it was telehealth. And speaking of telehealth, you need the consent to telehealth on every single progress note. I am seeing a lot of people in my consults getting dinged for this on audits. Every single time they have to consent to it. And I took another training and they were saying like they actually asked the client every single time. In my opinion, I feel like if you have agreed to telehealth, they've signed the consents, they're showing up to the telehealth appointment, that is consent. You can just check that box. You also need to say how it was conducted. This is another thing that's newer that I'm seeing more and more often, people getting dinged on, is you have to say how you met. So, client verbally consented to telehealth, met with client via Jane HIPAA compliant platform. or Doxy or Zoom or Simple Practice or whatever it is that you use. You need to document that as well. Any relevant history, this is really more for the assessment. And the assessment, there are very specific things that Medicare and Medicaid want in your first session with a client, and you do need to do a biopsychosocial assessment the first time that you meet with a client. I've met with consulting clients before, and they'll be like, we don't do that. We just say we had an assessment, and then we just have a diagnosis, and then we just start billing. You can't do that. They need to see a full biopsychosocial. And again, there's very specific things that they want on there. So any findings that you have from that, if you are doing like a GAD-7 or a PHQ-9 or anything like that, make sure that that is on there. And then the treatment that you provided. So when you're writing your note, I always think of it as, you know, the format can be whatever you want, but for me, it's like, we check all these boxes. This is how the client presented. This is what I did. This is how the client responded to that. And then any follow-up. So you'll want to talk about the treatment plans that were worked on as well. So documenting, we worked on coping skills related to managing clients' anxiety around work, using DBT distress tolerance per goal 1, objective 1 of the current treatment plan. That's how I would write that. Does that also help show the medical necessity? This is also really important. And I think I just did this training today, and there were questions about this and questions about like, well, does it really matter because they don't ask for it? I just bill and it's fine. Well, if you get audited, it will matter. You need to justify that. And when you are billing, you are agreeing that you have done all of these things and that you are meeting the minimum requirements. And it's up to us as clinicians to document medical necessity and show why this client needs our care. How is it returning them to their baseline? How is it helping impact their functioning? What is the impact it's having on their life? How is it helping them not go to a higher level of care? So all those things are really important. And something I haven't said yet, but that I try and say in every training is that when we're talking about compliance and audits, I don't want to scare you. And I know that it's a lot of information and it can feel really scary, but my goal is for you to feel empowered, because you and your client are the expert in their care and what they need. And we do need to do things a certain way to make sure that we are meeting those minimum requirements and doing what we need to do. But it's really just your job to write all these things appropriately so that if you do get audited, and I hate to tell you this too, but they are becoming more and more common, especially as we move towards value-based care, you have everything ready to go. And that way you just send it off and you know that you have done it correctly. And that's why prevention is key, and using systems is also really helpful. So anyway, that's that tangent. Back to here. The next thing that you need is your provider signature with credentials. If you're doing paper notes, it does need to be a wet signature. If you accept Medicaid, they are very particular about timing on entering and signing documentation. So make sure you check your manual because they will look at that. When I was audited by Medicaid, that was one of the things that they checked and made sure that we did our notes on time. If you're a Medicare provider, for outpatient, this is not the same for like clinics or facilities because that's a totally separate credentialing process. But if you are just routine outpatient, group practice, private practice, I have never seen Medicare with requirements for entering and signing notes, just that it needs to be timely. To me, timely is like 48 hours. So I think that's usually pretty good, but the sooner the better. And then of course, time spent, duration. So I know that seems like a lot. However, your EHR might already have a lot of these things on there. And then of course, templates can be very helpful. I'm huge on templates and having checklists and things to make your life easier. At the end with my contact information, I have a link to my Etsy, but I sell my progress note, my assessment template, a discharge summary, a couple other things on there. And if you just search GJV Consulting on Etsy, they will come up. But I'll have a link to that too if you're somebody that wants something to see for your practice or your clinicians of what you should be having on there. So I know that most people here, or all of you, I don't think anybody here is committing Medicare fraud. I think a lot of things happen unintentionally, but there is in general a lot of Medicare fraud, and that ruins it for the rest of us. And that is why audits are happening more and more, unfortunately. So I know it doesn't feel fair, but that's why prevention is so important. So common reasons for audits, documentation issues with missing signatures, incomplete notes, or late entries. Billing patterns are a really big audit trigger, as you can see as well. Unusual volume, high-level codes, or time discrepancies are what we see most often here. Unusual volume is really more like if you're seeing a client 4 or 5 times a week and you're just an outpatient mental health practice. That's not routine outpatient mental health care. That's more of like an IOP or maybe even a PHP, depending. So that's where they're going to look at that stuff. Medical necessity, insufficient justification, and missing orders. So missing orders, we don't see too much in mental health, depending on what kind of stuff you're doing. Orders are usually for neuropsych testing in our area. So I know I put that on there and people are like, what missing orders? You probably don't need them. If you are a Medicare Part B provider and you do routine outpatient mental health care, you don't need a prior authorization. Hold on, I'm gonna get a drink of water. So, like I said, a lot of Medicare fraud, not necessarily us, but these are the top areas where there's been recovery, aka recoupments, where they have taken money back. So when they see these errors, that's where those clawbacks or recoupments come from. So coding errors, medical necessity is a big one, documentation, and then time-based services is another big one. And those of us in, private practice, or if you're doing mental health, we bill time-based services. So we bill 90837, 90834, 90832. And there's a lot of fraud with that. So there is a ton of fraud with billing, not necessarily anybody here, but people billing 90837, but they only saw it like for 42 minutes. So, and the opposite as well. I hear this a lot too, where people will say, I am afraid of billing 90837 because I don't want to get audited and I'm afraid, but I saw them for 60 minutes, but I'm going to bill 90834. That's also fraud. You should bill for what you did and just document appropriately. And that's why we're here today, to talk about that so that you can feel confident and empowered in what you're doing. So common billing errors to avoid, I just talked about one. And also upcoding services. So that's kind of what I was just talking about. Unbundling procedures, we don't really deal with that too much in our world. Missing or incomplete documentation. Duplicate billing, if you are using an EHR, hopefully this doesn't happen too often because there are safeguards in place to prevent that. Incorrect place of service. I'll just tell you right now, if you're billing telehealth to Medicare, it is place of service 10 with no modifier. And that did change, I think that was this year, because it used to be modifier 95. Now it is place of service 10, no modifier for telehealth. If you are doing audio only, which is covered by Medicare, it's place of service 10 with modifier 93. And of course, check your Mac. This could change. Telehealth stuff is up in the air. There is a lot that is potentially happening with that this year. I am following it. The other place to get information is if you're a Medicare provider, your Mac, they all have an email newsletter. And if you're not on it, you can just go to your Mac's portal and opt in for those emails. That is a really good place. And then I also send emails when I'm aware of any changes that are happening. And I also post them in my Facebook group, which is called Medicare Consulting for Therapists. So you can also join that. And then also just being involved with your state, with your boards, with your discipline. The Clinical Social Work Association sends emails about these things as well. I'm not a counselor, I'm a social worker, so I don't know for sure if the ACA does. I assume that they do, but I don't know. But I know that NASW sends a lot of information about that. So those are good places to look as well. Okay, what else? Missing physician orders. Again, we don't really deal with that too much. Invalid supervision levels. Incident to billing is very specific with Medicare. Medicare, I don't even know if I have a slide on this, but I'll tell you right now. Medicare does not cover incident to billing unless it is incident to a psychologist. The psychologist needs to do the 90791, the first session. They need to be on site and available, and the psychologist and the associate both need to be W-2s. I have also seen a lot of pushback on this when people get audited. So be very, very careful if you are doing this. I had a healthcare attorney tell me to not do this. But it is there, it's out there, and they have procedures on it. So being very careful if you do that. Medicare does not cover billing for associates. So to a master's level. So if you are an LCSW and you have a social work associate or a permit holder or registered intern, it's different names in every state. Somebody who doesn't have a full independent license, they cannot bill under a LCSW, an LMFT, or an LPC. Anybody with a master's level, they cannot bill under. And be very, very, very careful if you are going to do this. I have seen a lot of things and a lot of recoupments, so just be careful with that. And then improper use of modifiers, that usually will just get claims rejected or denied. So this really does depend. State specific might be longer, but I have 6, 7, 10 years for these. So making sure that you're just keeping your records. If you use an EHR, that will make things a lot easier. If you are using paper, making sure that you have them saved and that they are have the access requirements and all those things per HIPAA. So some high risk areas that we've already talked about are documentation deficiencies, incomplete notes, putting things in late or missing signatures, not justifying medical necessity, doing an inadequate assessment where you're not covering everything that needs to be covered, and billing problems like missing modifiers, the wrong times, or using the incorrect codes. And these are things like I don't know, as a group practice owner, I remember when I was just a baby CEO, and I just kind of assumed everybody knew these things. And then I would read my clinician's notes, and she would write something like, met with the client for 20 minutes, and yet it was a 90837. So little things like that, you want to just catch early and make sure you're doing training with your team on those things, which is what I'm going to talk about here. So essential protocols, very important. Because when we don't do these things, it's not just getting an audit and possibly having to pay back money. This can, if it's really big, it could damage your reputation in the community or with the payer. It can lead to more stress between your staff and burnout, which means that people are going to leave. You're going to have more administrative burden. You are going to have to spend more time and money onboarding and training people, and you might have other costs like having to hire an attorney or a consultant like me to come in and clean things up for you. So written policies and procedures, again, I am huge on systems and having clear standard operating procedures. I also think it's really important to remember that we are all different. I am a neurodivergent person, and there are a lot of us out there, and we all learn differently. So making sure that these are not just written, but you have videos, and maybe those videos have captions. You want to make sure that it is accessible in the best way for your staff. And one of the biggest reasons for people being burnt out in general is unclear expectations. So having those really clear guidelines is very important. What do we do with this and this and this and this? What is the process? Having regular updates, making it in a central place, whether that's like an intranet that you create for your business, or using Google Drive, or using something like Trello or Notion, making sure that people know where the guidelines are when they need them. And that will make things run much more smoothly when things are streamlined. So staff training, initial orientation, onboarding is hugely important. I don't know if Maureen Werbach talked about this when she did her training with Spruce, but I thought of her because she talks a lot about onboarding and the importance, and I totally agree. Staff, when they're being onboarded, whether this is a clinician or your front desk, they need to know what their job is, what is expected of them, where to find those guidelines, and also knowing that a task that takes 5 minutes to complete is usually 20 minutes of explanation. So making all that clear, again, making it accessible, whether it's videos, PDFs, both. There are tons of AI tools out there that can help you manage all of these things. And then it's just a one and done. And then you just update it regularly as you need to with your annual updates, and then any ongoing education when things change. And then I also am huge on regular audits. I find that people, I can't say everybody, but in general, when I'm consulting with people, I find that this is something that comes much later after something has already happened. So be proactive about this if you can. Have regular internal audits, have billing checks, have documentation reviews, have a process for that. Your clinical director or whoever, depending on how your practice is set up. I also do these as a consultant, but have somebody who goes through and is doing these regular audits so that we are catching things before there is a problem when Medicare or Medicaid or a commercial insurer is looking at them. So some red flags that can trigger audits. I always get asked, how can I avoid being audited? You cannot. I hate to break that to you. That's why I'm so huge again on just being proactive and being preventative with these things. It's hugely, hugely important. I have worked with people who got audited from Medicare who have one Medicare client, and I have seen people who have thousands of Medicare clients and haven't been audited yet. So, and everybody in between. But there are some things that can quote unquote trigger an audit, or that they will look for. So unusual billing practices is one. So that might be like, I don't know, billing 90791 multiple times in a year, billing 90837 3 or 4 times a week, which is also high volume, using things like interactive complexity or other add-on codes can be a trigger for audits. They basically look at things that are like unusual billing practices when they're looking at these things. So just making sure that, you know, things are as they need to be, that we're billing what we do and what was done. And again, that your team, if you have a team, knows what's expected of them and knows what to do. I know that like sometimes I would have clinicians who, you know, I'd be reviewing things and I'm like, why did you see somebody for 3 hours? Like that happened once. And I'm like, what was the expectation here? That was maybe something that I missed, right? Or trying to bill case management, or calling a client to check in on their next appointment, and they would try and bill that as a session. And I'm like, that's not billable time for Medicare anyway. So for some tips to have daily best practices, document at the time of service if you can. I know this is not always possible. And if it's not, I think understanding why. I know for myself, I used to get super behind on notes. Yes, I train on documentation, and I also was behind on my own notes. And that is because in the beginning, I didn't know. what was expected, and that just felt really overwhelming. So I didn't know what to write, and I was worried about it, about doing it wrong, so I just left it. So if you struggle with your notes, or if you have clinicians who struggle, the why is going to be really important here. Maybe it's something like that. Maybe they just feel really overwhelmed. Having templates can be super helpful. If you want to, using AI can be really helpful. I know that there are mixed feelings on that. I don't want to get into that, but I just want to say that that is an option for people who do want to use it. And there are plenty of HIPAA compliant platforms out there. You just want to be really clear that it is meeting the requirements, because just because AI does the note for you doesn't mean that it's documenting medical necessity correctly. AI doesn't know the Medicare and Medicaid requirements. At least ChatGPT doesn't, because I ask it all the time and it is wrong. So make sure you double check if you're using things like that. Do specific individualized notes. A lot of EHRs have a load previous note option, which is fine to use that, but you cannot copy and paste the same note for a client every single week or for multiple clients. It needs to be individualized. It needs to show how it was meeting medical necessity and how you are working on their treatment plan. Make sure you include all those required elements that I already talked about, like start and stop times, making sure it's signed, duration, medical necessity, huge. Time documentation, also huge. Ensuring proper signatures, and then of course just being organized will always make things a lot easier if you do get audited. It should, most EHRs have a very simple data export thing, and then you just send it off and it makes it very, very simple. So I just wanted to share this because I was proud of it. This is from a client of mine who had a Medicaid audit, and they had 0 findings after they consulted with me. So I was very pleased to report that. So I want to share that, not to toot my own horn, but just to let you know that if you have good practices in place, you can also pass Medicaid audits, and it doesn't have to be that scary. Okay, so HIPAA, also compliance situation that we need to talk about. It's very important. First of all, using, if you're a Medicare or Medicaid provider, you are a HIPAA covered entity. So you need to use things that are HIPAA compliant, like Spruce, to consult or to communicate with your clients. And you can, I'm not going to go into a deep Spruce thing here, but I will say there's a lot of things that you can use Spruce for that are super helpful, because you can put tags on clients, you can add them to wait lists, you can message back and forth about clients in there. So that's super helpful when we're thinking about HIPAA, especially with number 3 for BAAs. So if you have front desk, admin, virtual assistants, they need to sign a BAA, and they should be using something that's HIPAA compliant. So making sure that you have those on file, especially for any contractors or subcontractors. If you use your ROIs, which I think a lot of us have this for our clients, must include all of these things here. Your notice of privacy practices, those, a lot of people will just call those like the HIPAA consent or something like that. Or your informed consent, your privacy practices, whatever you do, it has to have all of those required elements there. And then security risk assessment documentation. This is really more for larger entities. So if you are a facility, if you are like a hospital, or if you do any IOP, or your community mental health clinic, these are the things that they'll be looking for as well. And you will get the slides, so you can use this as a checklist if you need it. And then for Medicare and Medicaid. So for Medicaid, they will, well, I can't say for everybody, but generally, if you get audited by Medicaid, they will ask for your privacy practices. They want to see everything that client signed before becoming a client with you. So like your informed consents and your financial policies and whatever else you have client sign. Medicaid in pretty much every state, not every state, but again, I'm just speaking generally here, they usually want clients to be aware of their Bill of Rights. So this is specific to Medicaid, and that just means that they are acknowledging where they can file a complaint. They're being acknowledged that they have Medicaid and they're not going to be treated differently because of that. So check with your specific state on that. They will also want to see, again, initial patient documentation that you are getting permission to bill their insurance, their assessment. So your biopsychosocial assessment does need to be completed to their requirements. And the treatment plan, also important. Yes, everybody does need a treatment plan. It does need to have SMART goals on it. And I talked briefly about this. I did another training with Spruce a while ago, maybe that was last year too, on audit proofing documentation. And I believe that's on Spruce's YouTube, and you can go back and watch that too, where I go more in depth in this. And then with Medicare, there's also something called an advanced beneficiary notice, or an ABN. We don't use this too much in Medicare if you are a Medicare provider, because this ABN says that Medicare patients may have to pay out of pocket for something that potentially could not be covered. So we don't see this too often, because if you're a Medicare provider, you shouldn't be billing people out of pocket for things that are covered. However, there could be a situation like maybe a client comes to you, they have Medicare, you do your assessment and they don't have a diagnosis, and you are a Medicare provider, but that's not something that can be covered because they don't have a diagnosis. So that is a situation when you could maybe bill a Z code and then bill the patient out of pocket. Or another thing I'm seeing a lot is multiple 90791. So you bill 90791, but the patient or client has already seen another provider this year and it doesn't get paid. And then that way, if they signed an ABN, you can charge them out of pocket for that. So then ongoing documentation, obviously your progress notes, any treatment plan updates or treatment plan reviews. If there's supervision involved here, then you want to document that. And then your financial documents are here. If you do, this isn't really related to Medicare or Medicaid, but if you do sliding scale, you want to have that documented too in your process for that. You know what, another question that I just thought of is looking at payment policies is that I get asked a lot is, can Medicare clients pay a no-show or a late cancel fee? And the answer is yes, as long as it's in your payment policies and if they do not have Medicaid secondary. So this gets a little nuanced because there's different types of Medicaid, and there's something called QMB, which means qualified Medicare beneficiary, and that means Medicaid pays for the Medicare premiums, and in those cases, they cannot pay out of pocket for anything. And you want to check your state's Medicaid. But I generally just blanket statement say if somebody has Medicaid, don't charge them out of pocket. That's usually like the best way to CYA. But if somebody just has Medicare and a supplemental and it's in your practice policies, you can definitely charge them a no-show or a late cancel fee. That's a very common misconception I see all the time. So as far as compliance stuff, you want to have your staff documentation. So if you're a group practice owner, if you're solo, this really doesn't apply to you. But if you have a group practice, you'll want to be keeping all this stuff in your, however you do it. If you have a CRM or if you use an HR system, making sure you have those training records saved, the license verification, background checks, any acknowledgements of like your employee handbooks or things like that, and any confidentiality agreements, and then your written policies. So hopefully no corrective action plans, but that does happen. But your written compliance plan, any incident reporting forms, and any annual review records. And then for your audit documentation, having checklist template spreadsheets for external audit responses if you've had those, any corrective action, any quality assurance reviews, and internal audit worksheets as well. And these things I will tell you, if you ever want to sell your business, and even if you don't end up selling your business, I will tell you when I sold, these things were asked for. So you need to document everything. If you have a group practice, all of that stuff needs to be documented. If you are a group practice, you're going to need your HIPAA training. So people should be doing that annually. And also, and you'll want to document that they attended and all of those things. Medicaid in most states, not in every state, but in most states also wants a cultural competence training. I haven't seen that for Medicare, maybe for facilities, but Medicaid does want that as well. And then of course, making sure you have your written policies for this, HIPAA, more HIPAA stuff. Record retentions, check with your state because that changes as well. So I'm going through these kind of fast because I'm looking at the time and I have more stuff to talk about. So if you are a larger entity, you'll want to have a compliance officer. That's something that HIPAA wants. If you are a Medicare or Medicaid provider, you are a HIPAA covered entity. That means that you need to comply with HIPAA. So you need to communicate in that way. You need to make sure that you have policies and procedures around this, that you have a breach response plan, that your, again, your communication is HIPAA compliant, your website, all of those things are very important. And I would say Medicare doesn't necessarily audit this stuff too often. It's more for the larger entities that I see this, but that doesn't mean that you don't have to do it. And as far as ongoing maintenance, you'll want to have for your staff, again, if you're a group practice, your annual HIPAA training. If you are a Medicare provider and a Medicaid provider, you'll need a fraud, waste, and abuse training. There are a ton of free ones out there. I think CMS even has a free one, and there's a bunch of low cost ones as well. So you want to make sure that that is on file. And then if you are a Medicaid provider, again, blanket statement, it does depend on your state, but you'll want a cultural competency training as well. And you'll want to have all of that documented somewhere, and make sure that you have your regular staff trainings and that you have your annual policy review with your staff as well. So as far as systems and best practices, again, this is the stuff that burns people out. We have lots of tools to help us. We have AI, we have Spruce, we have EHRs, we have project management tools. There's Loomly so that you can record videos. It's all really just about having systems and automations that will help your business and your practice thrive so that this doesn't become an ongoing stressful thing. But if you use an EHR, can't stress this enough, that there are so many tools that I find people don't always use. So make sure that you are using your EHR and even something like Spruce to its full potential. You are using all of the things that you're paying for, like those integrated forms and reminders for clients, reminders for you as a clinician that you are tracking things, tracking if things are missing signatures, tracking if there is missing documentation or billing, all of those things. So using your EHR for that. If you are still using paper records, then just making sure that you have standardized forms for everything, that there's controlled access and secure storage so that you're storing everything behind 2 or more locked doors, and that you also have regular audits and tracking systems for yourself if it's not all automated. And then if you're using both, that's fine too, but just making sure that you have consistent policies and that you are cross-referencing what you need to. But if I don't shame anybody for using paper, because that's how I started my practice, but I will say, like, using an EHR will just make your life so much easier. So if you need more help, CMS has lots of very exciting reading that I would recommend reading at night because it'll put you right to sleep. But they have a provider manual. Every state Medicaid has a provider manual. Local coverage determination is from Medicare, and that has their expectations for what documentation should look like. It also tells you what CPT codes are covered and what diagnosis codes are covered. So if you have questions about that, it is all out there on CMS. I know it's hard to find. I have a lot of links on my website as well. Your professional association, and then your MAC. So that's your Medicare Administrative Contractor. They give lots of updates as well. So get on their email list. I would also encourage you to get on my email list because I send updates as much as I can also. And that is all I have for you today. I wanted to make sure we had time for questions because I know we have some. If you want to connect with me, connection is really important to me. You can follow me on Instagram. I'm at GJV Consulting. And if you're on Facebook, I do have a Facebook group for Medicare, and that's Medicare Consulting for Therapists. You can just search that on Facebook. And then it's the same name for my website, medicareconsultingfortherapists.com. On my website, I have tons of free resources and videos and podcasts that I've done under the resources tab, where you can read my blog. All that stuff is free. And I also have paid live and on-demand trainings on Medicare credentialing, Medicare billing, and documentation. And finally, the last thing I will tell you is on my Etsy, I do have those progress note templates and other templates as well. You can either scan the QR code, or if you just go to Etsy and type in my initials, GJV Consulting, those will pop up and then you can get them from there. So I really appreciate Spruce having me again today. I see we have some questions and I'm happy to take some time to answer those.
Brilliant. Thank you, Gabrielle. That was so much incredible content and you got through it so quickly. I love it. Let me get you through some of these questions that came in. Okay, so the first one that came in says, if I buy the template, can I upload it on my EHR?
It depends. So every EHR is different and they all have different rules. So you need to check with your EHR directly. I can tell you if you're a Jane user, they have a template library and my template's already uploaded in there. So if you use Jane, you go to the template library and you search my initials, GJV, my progress note and the assessment will pop up. For other EHRs, it just depends. I know with Simple Practice, they don't allow you to upload it. You have to create it yourself. So you would buy my template and like use it as a guide and then go through Simple Practice and add everything.
All right. Okay, good. Thank you for that. Rachel is asking, where do you get the orders from for neuropsych testing? The PCP?
Yes, their primary care doctor.
Okay, perfect. Can you talk about the modifiers again? I am outpatient mental health practice and are in network with Medicaid. We no longer use modifier 95 for telehealth.
So that depends. So for Medicare, you don't use modifier 95 for telehealth. For Medicaid, I can't answer that because I would need to know your state and I would have to research it. So for Medicaid, I would tell you to check your Medicaid, your state Medicaid's billing manual, or reach out to your provider rep.
Perfect. Samantha is asking, how do audits verify/check the time of service, just based on if we document the exact times in the note?
So if you were handwriting your note, they'll look at the times that you wrote on there. If you are using an EHR, remember that everything you do in there is timestamped. So there is a log of every single click, every move you make in your electronic health record. So your EHR will show, especially if you use telehealth through your EHR, it will show you when the meeting was started and when it was ended. Otherwise, in your EHR, it will have that timestamp on there as well as when you write it in.
Very good call out. Okay, let's see here. Is AI authorized to be used for documentation with clients? And if so, which ones?
I don't know that I would say it's authorized. I have not seen anybody say that it's not. But you do need to be very careful that you are using something that's HIPAA compliant. So if you're just using ChatGPT, you cannot be writing in there. Carrie Scott came to my session today at 1:10 p.m. and she was a hot mess and blah, 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 blah.
Yeah.
So you cannot put any client information into Chat GPT. There are tons of HIPAA compliant AI note takers out there. A lot of them record your session, which again, I'm not saying anything about that. I know we have mixed feelings, but that is an option where they record the session, they take what you said, and they make your note, and then it's destroyed. So that's an option.
Okay. All right. Rosemary is asking, should we go back and fix things that might not be in our notes after hearing your presentation?
No. So that's a really great question. Legally, you can't and should not do that. Those notes are done, they've been written, they've been locked and signed. So if you wanted to, you could go back and add addendums, but that would be a lot of work and you would need to explain why for each one. So leave those as they are, and then going forward, you can make the changes that need to be made.
Perfect. An anonymous attendee is asking, I understand that insufficient medical necessity can trigger an audit, but how does Medicare know if there's insufficient medical necessity prior to the audit?
Ooh, this is a good question. So really what they're looking at is like you build 90837, why? So they might not necessarily know before, but they could. So you might bill for something that's not covered, or you might bill for, I don't know, something unspecified, and you're billing 90837 for that, and they might deny the claim.
Okay. All right, great. If you don't take the client's supplemental plan, are you able to still see the client with their original Medicare?
Ooh, this is a really good question. So, if a client has a true supplement to Medicare, so that means it's this is a whole nother thing, but I'm gonna try and make it succinct. Supplements are like Plan G, Plan F, Plan N, Plan L. There's all different ones out there, but if it is a true supplement or what's called a Medigap plan that is set up to just work with Medicare, you don't have to be in network with them in 99% of the cases. They're not meant for you to be in network with. They're just set up to pay that 20%. So you bill Medicare, Medicare forwards the claim to the supplement, and the supplement pays you, and you don't have to be in network with them.
Okay. All right. Amazing. What is the difference between a client deductible and coinsurance?
A deductible is a large amount that they have to pay at the beginning of the year, usually, for something to be covered. Like for example, I have a huge deductible. Mine is $6,700, but Medicare is theirs is like 257. So that 257 threshold has to be met before Medicare is going to pay anything. Then a coinsurance is for each session. So the deductible is just that one-time thing that needs to be met. The coinsurance, for example, with Medicare, it's 20%, is every single time they have something billed to Medicare that's outpatient, there's a 20% coinsurance.
Okay, great. And I think we have time for one last question. Jenny's asking, does any cancellation charge policy statement need to explicitly state Medicare, or does a general policy for all clients comply?
A general policy is fine. So as long as you have it documented that that is something that you do and that clients are agreeing to it and that they're signing to it, then it's fine.
Okay. All right. Amazing. We got through the bulk of the questions. You have been amazing as always, Gabrielle. That was so much content and you covered it so succinctly in such a short amount of time. Just a reminder to everyone, I will be sending out a link to the recording and to these slides a little later this afternoon. Hopefully you all enjoyed this and got as much out of it as I did. This will also live in perpetuity on our blog for anyone who wants to revisit this at a later date or, refer colleagues to it. You have Gabrielle's information and how to get in touch with her. So please feel free to reach out if you want to learn more or have her consult for you. Gabrielle is just a gem, and I just look forward to having you back again in the near future. Maybe we'll have to have a part 3 since this content is so well received and there are so many questions and so much interest on it.
I am happy to help. I know that it is a lot. It's very confusing. I know I threw a lot at you all today, but you'll have the recording, you will have the slides. If you want to connect with me, all of my contact information is there. I'm happy to answer any other questions for you. And thanks again, Carrie.
Awesome. Thank you. And thanks to everyone who joined. Have a great rest of your day. Bye.